Hello everybody, and welcome to this MedTech West seminar. My name is Emilsson. I'm the director of MedTech West. And for those who don't know what MedTech West is, it's a platform for research collaboration in biomedical engineering. And we have 5 parties behind MedTech West, and it's Sahlgrenska University Hospital, the regional development of DDR, Chalmers, Kristofer University, and the University of Borås. This seminar today is about control and automation, and we have Kristofer Bengtsson here. He's a researcher at the Department of Electrical Engineering and System and Control. And his research is about automation and control of advanced systems, for example, production of different types. His focus in health informatics is on using AI and IT tools to improve planning and scheduling. And a part of his thesis was performed at NEL. So, welcome, Kristofer.
Thank you. My name is Kristofer, and I will sort of give a very, you can say, a general talk. So there will not be a lot of algorithms and details. So if you want to have that, you can talk to me afterwards. So it's more about the journey I had when trying to figure out the healthcare system, what is going on, and what can I as a researcher do to help out. But to really do that, I want you to give a little bit background of what we are doing in other fields, or more in the industry. So what our group, we are quite a big group working with automation, and we have been working a lot with Volvo and big production companies, and also other things. So I want to show some of what is going on. So this is a typical production system. This is actually at Saab. A lot of robots, mechanical things, and welding. And what we have been doing is how do we control it, but also how do we gather data. We want to understand what is going on. So we have developed this system to gather a lot of data from robots, machines. They have thousands and thousands of connected devices. So we can gather data live, and we can analyze the data. So we look at different tools. We can find sequences based on the data and see how things are working. We're also working with other types of systems to try to gather data with cameras. So we are flying around and trying to build 3D models of production systems. We are using AI to find what do we see with the cameras, can we use it for control, and what is going on. And then we are working a lot with control. This is an example from a student project. How do we actually control these systems, which are quite complex? How can we use robots to grasp things that are not really easy to grasp, like in a bin like this, using also different types of AI tools. We have student project where how do we actually interact with machines that are advanced as a human? Can we make them move and behave? And in this case, they have a sensor on the arm measuring the muscle to move around the robot. And here you can also see how can we use the robots to interact with humans. And these quite complex control tasks. This is another example where we actually use machines and humans working together in Skövde, where they assemble engines, and then we can see how do the machines and the humans interact. And it becomes quite complex, the different sequences and things how it's going on. Coordinating these kind of small AGVs, it can be in industries or healthcare, autonomous driving. This is a student project where they are trying to make this drive by itself. And this is a tool how we actually control it. And what I want to show with this picture is that in industry we are controlling systems like this. And usually you have a lot of what we call operations or activities. And these are happening in some kind of order. And in industry it's tend to be quite strict in what order they do things. But to develop and come up with what order they should do is pretty tricky. But when they had decided that, it takes years, but then they can sort of execute it. But our research is about how do we handle it when we have a lot of flexibility in the sequences, when something changes and we have to replan everything. And how do we actually handle that? Can we have support and help with that? And a lot of our projects are based on that we first try to gather and understand what we are listening to the system. We gather a lot of data, use algorithms to figure out what is going on, get an overview. Then, based on this overview, we try to update the control. Maybe it's a reschedule, a new plan, or we can just know we are controlling this, lower the energy use, or help in the interaction with the robots. And then in the end, we try to learn what we have listened to the system, so also the next development of the systems is correct. And now your question is, of course, how this really relate to healthcare. And of course, I didn't really know that before I started my study, so it was now it's actually quite many years ago. I had a friend working as a verksamhetsutvecklare at NÄL, and we started discussing what he had a problem. He worked at that time. Everybody talks about lean in healthcare, so they did workflow diagrams, and it was really tricky to understand the processes. They realized, oh, it's hard to draw these workflows diagrams because it was so complex and it just grew and was very like we call it spaghetti diagrams. And then I realized, it sounds that you have the same problem we are trying to solve for industry. That it's when the sequences and processes are more complex and when they are changing, it gets quite complicated for the human mind to understand all the dependencies of this. So I started to maybe we can look into what you are doing. And I ended up at an emergency department and spent a couple of weeks at the apartment at NÄL and spent a lot of time talking to them, looking at what they were doing, and sort of ended up with some what should I say, observations. And so I wanted to go through the observations before we continue what we did after that. So the first thing I sort of saw that at an emergency department, the key is to get an overview of what is going on. And so I saw that overview of what is happening at the emergency department was directly related to the quality and working conditions. And perceived chaos will create chaos. Sometimes when they thought, oh, now it doesn't work anymore, sort of the quality went down at the emergency department. Other days it was the same load on the department, but they had another mindset. It sort of made everything work better. So I thought, sometimes they have a better overview of what is going on, and sometimes it's a little bit, they feel that it's a little bit chaotic. And when you are juggling all the balls, you are sort of, suddenly you can, oh, now it's too much, and everything is falling apart. And that was quite obvious when you were studying. And what I saw was also that the processes are very complex. They are changing all the time because there are unique patients, that things are happening. And so you need to understand, you need to have support to get an overview. It's not just one picture. You cannot look at just one patient, or just one overview of everything. You have to work with the data to get an overview. And I also saw that you need to understand what has happened. You need to understand now, and you also have to have some feeling about what will happen in the coming hours. Sometimes they discovered too late that all of a sudden we got 50 new patients, and a couple of hours later they realized, oh, we should have started earlier with this working a little bit faster. Another thing that I sort of saw directly when I come there is what is actually how you measure is also directly related. So at that time everybody talked about 90:e percentilen av tid till triage. That was the most important measure, and they put it on the whiteboard every day. And then when I talked to the nurses in the triage, they were really stressed about this time, because they couldn't really help it. If 10 new patients arrived, they were really stressed, and it didn't really help because they couldn't influence that measure. On some level, it's interesting to see that, okay, it's important to see the patients we actually have at the emergency department as soon as possible. But for the nurses, it was a really bad measurement to guide the thing you did right now. I think it's important to focus the measurement on to get an overview. The key is we need to overview what is going on right now. I think that was a big take-home message. And I also saw that you should work with continuous improvements and not sort of have this blame that they had. And they really sort of realized this, and we had a lot of discussions about that. And maybe the biggest thing is that the need to focus on the patient plan. I think that is sort of one of the most important aspects. So the personnel are extremely good at what they do. When you go to the emergency department, it's not really stressful if you go around, and they are very good at doing things with the patients and the task they are doing. It goes really smooth, everything. But the problem is that they have to multitask or multi-switch all the time. So when there are not much to do, they can sort of work. But when they get too many things to do, the switching between, or the fragmentation of what they do, gets too much. And sometimes they handle it, and sometimes they sort of drop the balls when they're trying to juggle everything. It's called cognitive overload. And it's one of the most common things, I think, at the emergency department. And it turns out also that it's related to not only who is working, but who they are working with and what they feel that day. So the same people can work some day and it works really well, and the other day they get this cognitive overload. And then the processes at the emergency department really goes down quite fast when this happens. And they are really aware of this, all of them, and because they are living in the system and understands this when you talk to them. But it's hard for them to say, okay, how do we actually get out of it? I also did some research about what do the research says about this, and what we have seen is that fast tracks is a very good way to solve overcrowded emergency departments. It's the only thing really that has shown when you do studies that it really helps. And of course, one thing is that you get usually not very sick people faster through the emergency departments. You don't have a lot of old but not very sick people in the emergency department. That takes a lot of time. But I think the main thing is that it's a very clear process of what you should do with the patients. So it's a well-defined sequence. And you also see that when you study the more emergent or trauma care, it's no problem at all. The trauma care and everything that is really emergent is no problem. It works extremely well at, I think, pretty much any emergency department, and they are very good at NL. So it's no problem at all, but of course the rest will be impacted by that. But I think that Is it because they know what to do and it's well defined, and they don't need to have all these things going on in their head when they are doing this? And I also saw that it's essential to change gears at an emergency department. When it's not so many patients, maybe you shouldn't do the triage. Maybe you should directly go to a doctor and do that. But it's really hard to change, and because they are really a little bit afraid of changing where people are at an emergency department, because you lose overview. I think that was, so it's better to work the same all the time. So based on this, I sort of, this was just when we were there and discussing with them, and sort of these key points came up. So I draw this picture. So for me, it was the key challenge they have is to get an overview of what is going on right now. Of course, to also understand a little bit what will happen in the coming hours, so they can adjust accordingly. To get an overview, you need to understand what are the activities that are happening now and what will happen the coming hours. So that is the plan for the patients are crucial to really understand what will happen in the coming hours. Also, how you measure will influence the overview. If you don't measure things, of course you will not be able to get an overview. One way to measure is to go around the talk, like they do usually today, or we can start working on different ways to measure and visualize and present the overview with IT support. And we can also use, when we measure, we can also use computers to help you predict things. When you have this, of course, the control will be much better, I would say. And it's much easier to work with improvement processes. So you can, in the team, think about, okay, how should we do better next day? So everything is connected. I think that is what I saw when I was there. It's something they really should think about. So before I continue what we did after this study, I just want to go back to this proactive. It's maybe a little bit unclear what the term means. So before this presentation, I looked it up on internet. So one definition was acting in anticipation of future problems, needs, or changes. So it's something you try to do. You are predicting things, and you do things now to sort of make the problems easier. Another definition is controlling a situation by causing something to happen rather than waiting to respond to it after it happens. So you do something to make things better. But proactive is used in a lot of different situations. It can mean a lot of different things. So I also found this definition. The things you do that you don't have to do that make all the difference when it's too late to do anything about it. And so it's a very unclear term. But in healthcare, when we talk about proactive, especially at the emergency department, it was quite obvious what we talked about. And it's a little bit plan ahead. And different persons are different type of proactive. But in this case, it's all about, okay, we do this examination. If we do this examination, we can get these different types of outcomes. Depending on these outcomes, we do these different things. But when you ask someone in the emergency department, why do you do this? And what does it matter what the outcome is? It's not very uncommon that no matter what the outcome is, they will do exactly the same thing afterwards. Because it's sometimes hard to think too much in the ahead of you. And it's a way of thinking. And so we're starting to think about how can we support the nurses and the doctors at the emergency department to think a little bit more ahead. Because if we do that, and if they can put it down somehow, we can actually do a lot of things with IT support to show what is going on, to predict things, and we can help coordinating a lot of things that is going on at the emergency department. But it's a lot. They need to start thinking about the future. And another thing that we saw was that the nurses in the triage, they were actually the ones that spent time with the patients and talked to them and had some ideas about what's going on. That was sort of lost in the way. They did some discussion with the next team, and they lose that information, and then they start over and think, oh, what should we do? And then the doctor meets, and sometimes they talk and sometimes they don't with the nurses, and oh, they start over, and they write the plans on different papers and have them in the head. And sort of and then you are changing staff. And when you have 20 patients with all these plans quite unclear, it can be very hard to remember, oh, this patient, we should have done this, or we're waiting for this response. If you have a lot of overload or cognitive overload, I think that is, and if we can help a little bit with that, I think we can solve a lot of the challenges or the stress a lot of the staff are feeling when you get it, oh, it's a little bit too much, maybe I'm missing something out. And it's usually the old patients that are not very sick but maybe should be admitted, or we are trying to figure out how to send them back to their homes. So it's so the thing, can we use the same ideas that we have been working on in the health or in industry also to get an overview in healthcare? So that is the short introduction. So proactive care for me is to define and follow a plan for each patient. Predict and plan for alternative outcomes. And also understand how that plan influences the system. If we only have one patient, it's pretty trivial. But it's when we have a lot of patients that it becomes complex. So the challenge is that this plan always evolves and changes. All the systems we have need to take care of that. We cannot have a fixed plan. It starts directly in the triage or when you start thinking about it. And it will impact the process when the plan changes. So it becomes very complex. I think the human mind is not very good at when you have a lot of activities with connections between them to figure out what is going on. But the computer is quite good at that. Just to give an example of what I mean. It's maybe a little bit unclear when we're talking about plans for patients, but it's pretty simple. So we have a patient, and what you do at an emergency department is to examine and decide, should we send this patient home or should we admit it to the hospital? Maybe you have more patients, so then first you have to do some registration, make the prioritization, triage, and then decide what team should it end up on. At NEL they have these sections that they can go to. And then you start, okay, first you do the registration, triage, but then they have a very aggressive triage nurse that decide, oh, we should do X-ray. And decide to that, and what you see is that the plan changes, it evolves, so suddenly you should do the X-ray, and you can also do the exam, and we can say this means that they can happen in parallel. Of course we can do the exam before, or we can just, if the X-ray is free, we can send it to the X-ray, for example. And the interesting thing is now, this is pretty normal. Okay, now we are waiting. What are the patient waiting for? That's the question. It's waiting for examination or that someone will bring the patient to X-ray. But why are the patient waiting? It depends on the examination, could have other activity, it depends on. Okay, before we do the examination, we need to make some tests or do something. So it could be other activities that needs to be completed before. So we have these activities, or of course we have resources or staff that can do an examination. Maybe we have two doctors that has that sort of ability to do it. So it's a matching. We have a priority, maybe something others should happen, and we also need to find who should do it. And so why we are waiting is based on if other activities or if what they are doing, the resources. So if we look at them, we can see that a patient plan looks different when we look from the resource plan. The resource plan is a combination of plans for different patients, or it can be other plans they have to do other things. But so we can sort of see what are they doing right now, and when can they do this, and based on priority and so on. So you see everything is connected. So the patient plan you can divide it on resource plan, and this is also the basis for scheduling, who is doing what. We can also look at resources, not only so the staff, we have resources can be rooms, other things that we can track, but it's all based on the patient plans. We can have static views showing information about the resources. And it's also the cornerstone of everything that is about planning and scheduling, trying to match all these things. And it's all based on this simple plan. So everything is interconnected. I think that it is very interesting to see if we can have some kind of process control. Or I could talk about processes. There are many names, but you can see it as the patient flow. But the process of patients, and I think that IT support is necessary in this system because it is quite complicated. Now you do a lot of this manually, and there is a lot of work, and especially when there are a lot of things going on, I think there are a lot of possibilities for IT support in these systems. And it's not an IT system that solves everything. It's an IT system together with the staff and the humans that should do this together. And so they should support and help the staff. So that is what we planned. Okay, we have this ID, we have this tool, not really tool, it's more of a concept, sequence planner, and we were thinking, okay, how can we support the staff at NEL? So then we were thinking, can we somehow integrate the tool with what they already do at NEL? So we can skip that. So this is the input they actually are using today. It's called Elvis, and if you're working at the hospital, maybe you know this tool. And this is how they track the patients. So it's they have some comments, and they have the last things that happened, and where they are, and what doctor they have seen, and if they have seen, and priority. And they can sort this list. But they are actually using this to type in information where the patients are. Actually, every ward at the hospital are using this to see where the patients are. And it's also taking care of other things, I think. But it was not very easy to get an overview of what is going on. So after some struggle with IT, we were able to connect to this database, and we gather everything that changes in Elvis. If you change the state with some parameter, we see that and send it out as what we call an event on a bus. And then on this bus, or we can also add other things. We haven't done that, but the state of the patient is usually in a lot of different places. But the idea is to send everything out, and then in this framework sequence planner, we can add a lot of things to analyze and aggregate and find all these events for one patient, for a team, and we can do a lot of different algorithms related to this. And one big thing is that we can start visualizing things in different ways. And so the idea was, okay, we start with this and we start to think about, can we visualize something? So this is what we actually are running right now at NEL. So this is live from yesterday. They are showing where the patients are in different departments, and I will talk a little bit more about that. You can see all the rooms, which is occupied and not occupied. And you can also show different things. This is where they are, and you can sort the patients on where they are in the process. And you can move around. So it's we use it also in industry, so it's quite a flexible tool that we've developed. I think this and the map is actually what they are using mostly right now, because they really want that. And when it breaks down, they call me directly. Oh, doesn't work. And they can see where in the process the patients are. So it's actually the same information as you can figure out in Elvis. But you can see here they are, and what priority do they have in this? Yellow is lower priority, and red is the highest priority. And you can see if a doctor has seen them, if they are done, and we are waiting for admittance to the hospital, or if they haven't been seen by a doctor. So the coordinator directly sees what is the status of the team. And we have also been working with predicting waiting times. I will talk more about that, but predicting time didn't make sense, so they couldn't use it. So we have some other ideas about that. And then you have a map showing, and this actually also used by the ambulance personnel, so they know where to put people in it. And this is really simple. So we had students developing this. So they went to NEL. I helped them with most of the stuff behind the scene, but then they went to NEL, talked to the nurses and the doctors, made this, and then we don't want that, and then they changed it and tried it. So took quite many iterations, but I think that is the key to develop IT systems. You have to iterate a lot, because no one really knows how to present data. Yeah, we have different types of, this is more of a team view. Statistics, so we have saving everything so we can show statistics. So in this case, this is quite interesting. You can see how many patients arrive at that time slot and how long did they have to wait for a doctor. So you can see here in the beginning, so you should arrive around 9 at an emergency department if you are sick. I always do that when I'm getting sick. And you can see later on in the day, everybody has to wait, because then the bulk of the patients are sort of filling up the emergency department. And you can do different types of studies. You have a lot of data from these kind of systems. So we also worked a little bit with prediction and time. As you see, this is the time slot, and they are everywhere. So different patients wait different times based on priority and different things. So we try to limit, but it doesn't make sense to say predict waiting time, because the staff cannot really do much about it. If there arrive 15, 20 patients, there will be waiting time. And it's hard for the staff to do anything right now. Of course, it's a system, over time they can do things about it, but it's really hard to measure and really help them with that. So it didn't really help. So we have been thinking about, or we have tried using frequency instead. So we have teams, and how many patients do actually go from not seen by a doctor to seen by a doctor per hour. And then we can get a feeling for if this team is taking patients or is occupied elsewhere. However, when we talk about this, it's quite sensitive, because people feel that, now you're starting tidsstudieman and measuring the frequency and what is going on. And because there are a lot of complaints about AT-läkare that is really slow and so on. When we measure it and we take an AT-läkare, do this, and then really experienced is doing the same thing, it's not a huge difference with the connection, or when they talk to the patients and so on. But it's the feeling is, of course, everything gets a little bit slower. I think that we will not use it to find slow teams, but the problem is that teams disappear. Suddenly they get a trauma and that team disappears and the frequency goes down. And if the frequency goes down, no one knows that. So they will just figure that out 3 hours later when they have a lot of patients just waiting. Nothing happens. We're also thinking about how can we actually, what we really want to look at is how do we predict workload. But there are a lot of nice algorithms to predict things or what will happen. And at an emergency department, there are a lot of patients. So in NL, they have 250 patients per day. And there are a lot of data to predict things. So it's pretty easy to do it. The tricky thing is to decide what do the staff really needs? How can they get an input to know what decisions they should take, how to change resources, and what does it really gain? So the results, we have actually been running this tool now for 3 years, but it has actually, we've been focusing on this screen that you saw mainly, where they see the overview. We have not been working with the patient's plan, and that's something I really would like to start working on, and also continuing how can we go forward. So what actually happened was that we've been running it, and then we started talking to IT to get the software into a server for research, and that has taken quite many years now, and it's very unclear how we go forward with this. Now we are running this a little bit on our servers, and it's hard with research processes or projects in the IT side, I would say. But we're lucky that we got so far to get this connection, I would say. So if we have this, if we have the plan, if we have a good overview, and if we can predict possible outcomes, there are a lot of nice algorithms to be used together with the humans to plan and predict. And I think it is possible to improve the working conditions, because I think that is the key. We need to lower this cognitive load and help the staff with the processes. I thought that is my main goal in a way. And of course, I hope that will improve the performance of an emergency department. But right now, we have to focus on the staff. I think they are to lower their stress levels and so they can handle it better. After that, we can think about the next step. I actually had a talk with people from radiology a couple of days ago. So I just wanted to show you that when we have the patient plan at the center, we can sort of do more things. And they were interested in this, I'm not sure if you call it referrals, remisser. They got a lot of referrals to radiology, and then they wanted to plan where should this be, where should they do this examination, in which hospital and so on. They had a lot of problems with that. But as we see, a referral is sort of translated to a plan. It's not only the examination, it could be tests before and so on. And we also have different types of staff. So when this becomes very complex, you need a lot of different types of experienced staff. And you have a staff schedule. Usually it's 2, so one for the nurses and one for the doctors that doesn't talk to each other. The staff, the scheduling people. And if we have this, there are really nice matching algorithms that can help finding who should do these things. It's something we also use in the industry. And then it can generate, so the algorithms can generate some help out with this. But it can also help out with manually, because it will never be complete. There are a lot of things we don't take care of in the algorithm, so you have to manually modify it. But algorithms are really good at figuring out that, oh, you actually do something that violates the schedules and the plans, because that is what algorithms are really good at. Humans are really bad at figuring out all these dependencies. I'm not sure if you have tried to do scheduling sometimes. It's really hard. And of course, everything has to be feedback, so you iterate. But it's all based on this simple notion of plans and staff with abilities that we are working on in these kind of automation systems. If you look at one plan, so the radiology, they have the same thing as an emergency department, daily coordination. So they have this and they are planning and they need some support and overview and finding bottlenecks and monitoring things. So there are a lot of nice algorithms to get support today, also at our radiology department. I actually don't know so much about it, but from what they explained, there were a lot of coordination, a lot of patients, and a lot of emergency processes going on. So there are a lot of interesting things that could be done. And also, when you are with the patient at a radiology, there were quite complex things you had to do. And there are a lot of systems that you had to gather data from. So they really would like to have help with instructions on sub-level. What should they do? Gather a lot of information from different systems to present it as a detailed patient plan for each. And computers are really good at giving these instructions. They are good at validating that it's doing in the right way if we measure. And if we are using AI-based algorithms, like algorithms to figure out based on images and things like that, they are not magic. They cannot just figure out everything. So there are different steps to use these algorithms. You need a lot of information, feed it, and execute it. And I think that when we start, because in radiology, you can do a lot of things with AI-based image recognition and things like that. There are a lot of interesting research. But then suddenly it becomes more like what you saw with these collaborative robots. So the staff is working with the patients, and at the same time you have machines that automate a lot of steps and figuring out things. And there are a lot of things that can go wrong. You have to restart and figure out how things work. And you have big machines that work. So you need some kind of support when you are executing these kind of systems. Yeah, I think I can. There are a lot of things with IT support. I think we can skip that. So the next step for us as a researcher, now I don't know the status now, but they sort of decided on the new IT system. So I've been looking at that, and there are a lot of things that need to be studied, and it's a very adaptive system. So it's good. It's important that it becomes we adapt it so it actually works with this kind of thinking. I really would like to start working with the patient plan at an emergency department. I would know that at Östra they are working quite a lot with the patient plans, and how can we actually have more IT support for that. And it would be interesting to see how we can use this research in other departments, and maybe you have ideas of challenges that would be interesting to study. I think there is a potential. There are not much done for this kind of support for healthcare systems. I think that key is to start with the people working with the patients. If that works, it's easier to support also higher level planning systems. And also the data they add to systems is much more accurate. If they can use the data directly that they add, they will add the data. In Elvis, some of the data they don't really, it's just for measuring. They are not very good at adding the correct data. Yeah, I think that's. I think actually this can also help with the overload. So if you have better planning, it will help a lot with the mental load that patients or staff has. And if the data is correct, also the patient can get a feeling, am I waiting for? And also you can easily show the patient, okay, this is what is going on. And I think that it's pretty easy when the data is correct. That is something we can do. I usually, when I teach for students at Chalmers, I usually give this citation from Einstein. logic will get you from A to B, imagination will take you everywhere. And I think that we as researchers, we are really good at the logical part and making programs. But we need to work together to sort of make use of it and use our imagination to find new ways. And I think that if we can combine the IT support and we can combine our knowledge of algorithms together with your experience, the ones that work in hospitals, I think there are great potential in this kind of IT support, I would say. So, thank you.